hopefully. Anytime now. All right, perfect. So, let's see. Don't really want to do that. If I can make you guys smaller. Okay. Oh, I'll do it like this. Okie dokie. So I want to spend, as I say, a little bit of time talking about the HESI that's going to be coming up. And I think you're doing it next week, aren't you? Next Wednesday evening, correct? Is that right? I hope. Hello?
Yes, ma'am.
All right. Hey, you can please participate, mainly because I don't want to be talking to myself for 3 hours. I just did a 3.5-hour lecture earlier. But anyway, this chapter 20 is where we're focusing tonight. And I noticed in the HESI that there are a lot of questions related to delegation. So, oops, that's not what I want to do. I want to do it there. Make sure I got the right one up for you. Yeah. So let's have a look at some of the items, and obviously bear in mind that I don't have the questions, right? So I don't know exactly what they're going to ask, but I can give you some guidelines, and that's really what I want to do. So some of the things that I'm noticing is being able to triage, telephone triaging, a lot of the pieces that are to do with leadership, knowing how to delegate, what type of person you're delegating, whether you're delegating a task or a skill, all of those types of things. So some of the items that I noticed, and let me just pull up some of the cheat sheets that I had. Maybe I can't. All right. Planning of care, for instance, like if somebody has a respiratory situation, knowing how to plan of care goals. What would that look like? What are the goals for that patient? Safety components like meningitis. How are you going to manage that? And I think I sent you a big long list, didn't I? Did anyone see it in the announcements?
Yes, ma'am. Yes, ma'am.
You did. Was that helpful?
Yes.
It is? Okay. Okay. So going through some of these processes, for instance, in the ICU, how do you prioritize certain things? Meaning, you know, you've got, say, I don't know, let's just say you're in charge and you're prioritizing the type of patients that you've got, maybe the 1 to 2, 2 patients to 1 nurse type of thing. Maybe you're prioritizing somebody coming from another unit. They're not used to working there. How are you going to prioritize those types of functions, making sure that, of course, the patient stays safe, and that you also make sure your staff stay safe as well in their practice and what they're doing. How would you do the SBAR for something like a post-op bowel? Any idea? Do you have any ideas how you would do that? Do you remember your SBAR, for instance? Anyone? Do you remember how to do an SBAR?
Situation, assessment, background, and recommendation.
Yeah. So if it's post-op bowel, maybe it's you're the post-op nurse, right? And you may be talking to a med-surg nurse or something like that, and knowing how to basically give them a report that they're going to be able to utilize when that patient gets there. So those are the types of things that are important. Delegation comes up an awful lot, and that is predominantly related to client safety, so the patient safety. So when I'm looking in chapter 20, and I'm going to stop right there, I want to go to chapter 20 a minute, and I want to start looking at delegation. And you're going to be doing this. You're going to be the people that are delegating. You're going to be transferring the responsibility of care to some element, not all of it, from what you're doing to what that what that person is going to be doing under you. So I'm sure right now you're being delegated to from a nurse if you're working as an MA or something of that nature, right? And they're saying to you, I want you to go and do, I don't know, blood sugars on these 8 patients or whatever you need to do and report back. Ultimately, it's their responsibility. They're still responsible for that patient, but they've got to have trust in you that you're going to be able to do the right thing, true? And that you're not just going to make things up, and that you're going to do the care that they ask you to do, and that you're going to do it safely. So that is part and parcel of delegation. And on page 349, now we'll do the PowerPoints as well. I'm going to look at this. There's actually a flow chart of how to delegate and what that should look like. For instance, you need to know the Nurse Practice Act, and you also need to know your state laws regarding the state board, what is allowed to be delegated to and what isn't. Different states have different regulations as what is okay. And I think a lot of that depends on staffing, which is why we started delegating in the first place, right? It's all to do with staffing. Some places allow people to do a lot more just because there aren't as many nurses around. So, you know, depending on what state you live in, depends on what level the unlicensed personnel is going to be able to do. So, and that's important for the unlicensed personnel to understand as well. They may be working in one state, come to another, think that they can do what they were doing there and they can't anymore. So it's important to know these things. Tasks are delegated, practice is not. So for instance, I'm not going to delegate a care plan to my UAP, right? I'm not going to delegate things like giving meds to my UAP, you know, passing meds. That's not something that should be given to the unlicensed personnel. What sort of things do you think could be delegated to a UAP? Have you any idea?
Ambulating the patient.
Vital signs.
Say that again, I'm sorry.
Taking vital signs.
Yeah, taking vital signs. Maybe AccuChecks, giving the baths, right? That sort of thing. Those types of skills. Maybe emptying Foleys. Possibly maybe calculating intake and output. Possibly, I don't know about that. Again, you have to be careful, but making sure they're definitely charting, you know, hey, what did the patient eat? What did they drink? That type of thing, the intake, and they may have to put the output for you. Do any of you do any of that or not? No? Or any of you?
I do.
You do? Yeah. What else do you do, Tiffany? What are you allowed to do?
Pretty much everything that was said. In the hospitals, I did AccuChecks. In long term, we don't. Ambulate to the bathroom, like you said, empty Foleys.
Yeah.
I's and O's.
Those are the sort of basic things. These are tasks, right? These aren't things that you're then going to have to go, okay, well, now I've got the input and output. I have to figure out if that's good or bad. You just hand that off to your nurse and they deal with it from there, correct? So that's where the practice comes in as opposed from the actual task. They might let you do some dressings, you know, if it's a chronic patient, they've been there a long time and they've got a lot of trust in you, and maybe it's a daily dressing or something, and it's a dry dressing, you might be able to change that sort of stuff as well. So I'm not sure about that, but again, it just depends, you know, if it's a dressing that is just, it's fallen off and needs putting back on again, those types of things, maybe they'll delegate those types of tasks to you as well, you know. but definitely all of the cleaning and the turning and all of those things. Personally, let me ask you this, with you about to become RNs, do you think these things should be delegated or not? Do you look at the patient, meaning, I'll give you an example for myself. So when I started nursing as a nurse, I did whole care. So I would have 8 patients. Now we did have a UAP. There might be 2 for the whole floor for 36 beds. And they sort of helped, but it was our role to do all of the care. So we did holistic care, right? And in some ways, I liked that, because if I'm bathing a patient or I'm washing someone, do you think you can tell a lot from their skin as to what's going on sometimes, you know? Yeah. And sometimes those things can get missed unless you've got a great MA that really knows their stuff. Sometimes there's little things that can get missed. The same thing as well when you can be doing your assessment, right? As you're checking your patient and doing all of those pieces. That's part and parcel of it as well. If you're listening to the lungs and you're listening to the heart, you're checking your skin integrity, you're looking at if they've got any edema, they've got any petechiae, all of those types of things come into play. So while I do think it's important that we have UAPs and we delegate work, I do think there's part and parcel of it as well, that we still need to maintain that responsibility for what we're doing and for our actions. So anyway, on page 349, there is a nice little flow chart, like I said, regarding delegation. And I want you to remember, like I just said, delegate what is in their scope of practice. Somebody who's been a UAP, say, for 10 years, and maybe working on that floor and has a really good understanding of all of what's going on, is different to somebody who maybe has floated there, yeah, and they work in a completely different environment. Or you've got somebody who's brand new, and or you may have somebody, for instance, who I'm just going to say was a professional, healthcare professional in a different country, and unfortunately, for whatever reason, they can't get the boards or whatever the situation to be that in this country, and they may be a MA or something. So they may have that knowledge base and lots of great knowledge, but it still means you can't delegate. You can't go, well, you were a doctor in that country. You still can't go, I'm going to give them more responsibility because of that, right? Does that make sense? You still got to maintain what they are at this level. They're an MA or UAP or whatever is going on. So the other thing that comes into play is our professional judgment. And you have to judge those situations. You have to look at that whole clinical scenario when you're in charge of the floor and make decisions. Okay, I'm gonna put this RN with this group of patients, this RN with that one. I'm going to delegate this, I'm going to delegate that. And you're constantly making those decisions because you're going to be in charge. But guess what? You're also responsible, correct? So, you know, that's something to bear in mind. Let me just check, is everybody here now or not? No, Kayla's not here. All right, fair enough. I am just going to unpresent. Let me do that. Cool. And I want to, let me just minimize this. Okay, perfect. There, that's better. Thank you guys, by the way, for being on screen. It really helps a lot. I know it's, some people don't want to be and all the rest of it, but I do appreciate that you are predominantly on screen. That's nice. All right, so let's look at some of these other things. So delegation came up, client safety, that makes sense. Another thing as well, and I'm going to continue to talk about some of the delegation things, but multidisciplinary meetings, what do you think that means, by the way? And that does tie into delegation to an extent. Have you been in multidisciplinary meetings? Anybody? you know
Different
what that-
specialists, caseworkers.
Pardon?
Multiple specialists, social workers, caseworkers, everybody involved in the care of the client.
Yeah, and a lot of the time they'll round, won't they, on the units as a group, right? Going from patient to patient. It will also include things like the dietitian, speech, PT, those types of specialties as well. That's multidisciplinary as well, okay? But definitely the case manager or social worker is going to be involved in those types of things. Yourself as well, because as they're doing their multidisciplinary rounds or meetings, they're going to want your input. You're the nurse at the bedside. You're the eyes and ears seeing what's going on, right? So they're probably going to want your involvement in these multidisciplinary meetings as well. Let's see some of the other things. So here's another delegation. Delegation comes up all over the place in this, in your HESI. So COPD delegation, what do you think that might be, for instance? I mean, I'm guessing as much as you are, but I want you to be aware that respiratory COPD and delegation sort of goes together. So you're going to look at your ABCs, I'm sure, right? But it could be delegating in the sense of, does that patient need a nebulizer? What are we delegating? Is it food? Is it their nutritional status? And if it is, are we delegating to the UAP to say, okay, I want this patient to have these foods. Please make sure they have them so that they're getting their protein and that they get their fluids, all of those types of things. So again, part of the basic nursing skills, but COPD and delegation has come up. Let's look at another one, that restraints. Now that's a biggie, right? Restraints. Because I'm sure you as an MA, Tiffany, have been involved with patients that have restraints, right? Yes, no, maybe?
Well, the facility that I currently work at,
Mm-hmm.
they are not allowed to use any restraints, not even bed alarms, chair alarms. They don't use any of that stuff. But in other facilities that I've worked at, yes, more and so at the hospital.
Yeah. And so what was your role there? Making sure that the restraints stayed on, right? But enough, but they've got enough that they're not hurting themselves. I would think that's part and parcel of your role, isn't it?
Yeah, and they have to be checked on every so often, and like you have to mark it off that you did it.
Yeah. So you're checking off, like, I'm going to say every hour or every 2 hours, and whatever the protocol is. And that's part of delegation. It is a task. But in order to delegate that task, you've got to make sure that patient, that they're somebody trustworthy and that they really are doing it. Yeah. And I'm sure that's difficult in the long-term care, not having any restraints. Can't even imagine how that is. Very difficult.
We babysit, well, not
Yeah.
babies. We watch a lot.
Yeah. Yeah. So a lot of sitter service. Yeah. Which again is delegating.
Yes, but we're not allowed to technically call them sitters. Like they don't have sitters either, like one-on-one.
Wow.
So they sit up at the nurse's station or in the day room, something where there's a lot of people
Yeah.
around.
Okay. That's interesting. They're not allowed to call them sitters. I don't know that. Okay. But again, what I'm seeing over and over and over again on this HESI review stuff is this. So couple of the other things, verbal prescription. So taking a verbal order. Now I know, and let's look at it this way. That's a delegation, right? So if I'm calling the RN as a nurse practitioner and I'm calling you and I'm giving you a verbal, that's a delegation, isn't it? And delegating it to you, making sure that you take the order, making sure you repeat it back to me, making sure that you have that order that you can then go on and do what you need to do. So again, this just keeps coming up, but making sure that it's safe practice, that you're doing things legally correct, all of that. And again, delegation of UAP, which is what we're talking about today. So you can see why this HESI review, I mean, although I can't give you the actual questions, I would pretty much say chapter 20 hits all the high points for you. You know, so we'll look at some of the other pieces as well. Let's see. Some of the other pieces that I'm noticing, not so much to do with delegation, but suprapubic catheter care. So you know what a suprapubic catheter is, right? You remember what that is, suprapubic? So obviously infection control is a really big deal with this. These are more of a long-term type of thing, so I want you to be aware of that. Contact precautions, infection control, that's another big issue, but breach of that contact precautions. So, you know, somebody basically goes from one room to another room, for instance, and breaches that contact precautions. Maybe your other patient is neutropenic, something like that. So that's a concern, right? So again, I don't know necessarily what they're talking about, but if somebody does breach that, how are you going to deal with it? Certainly if you're in charge, what are you going to do about it? Are you going to talk about it? Are you going to, you know, I mean, I know that I want to say there was a student nurse from Concord who did breach contact precautions and was sent home, actually. Yep. She came out of one room, went to go into another room, didn't, she either, I don't think she gowned up and gloved up or something of that nature. She completely breached contact precautions and was sent home. And I want to say she didn't come back. And that was from the charge nurse of that unit, not necessarily to do with Concord, because, you know, contact precautions is a big deal. Remember what we talked about, how you can get dinged financially, right? If you don't maintain contact precautions, if you're not foaming in and foaming out, if someone develops a Corti or MRSA on all of these things. So it's not something to be taken lightly if you're breaching contact precautions in one way or another. So bear that in mind. Let me look at some of the other ones. Hepatitis exposure. So that's another issue, isn't it? Hepatitis. So we've all had our Hep B shots, right? We all had several rounds of the Hep B. So we should all be covered for Hep B. But what about Hep A? What about Hep C? There's still risks there. So there's still the potential. Hep C can live on a fomite, on a environment for a long time. So there are risks with these. I had a patient actually just the other week had elevated, I have a lot of patients that have elevated liver enzymes, and I tend to check for hepatitis just as a secondary precaution. She was a lady in her 60s, Hep A positive. Yeah, she was shocked. She had no clue. So, you know, the point is, so again, we have to be aware of contact precautions and hepatitis exposure. And what I'm saying by that is probably to do with blood, right? It's probably looking at blood exposure is what I'm thinking, the risks for hepatitis exposure there. So it could be something, unfortunately, that a blood spill or something of that nature. So again, making sure that we keep the patient safe and ourselves, right, with these types of things. An increased PT and a PTT. So it could be that we're looking at either heparin, because that's an APTT, right? And maybe bridging over from warfarin to warfarin rather. You know that, right? That you would go from heparin to warfarin, and you would go from an APTT to PT. Does that make sense? PTR. So if it's elevated, it could mean that the patient is, their blood's too thin, right? So that could be a risk, couldn't it? Risk of bleeding. You might be looking for signs and symptoms of bleeding or something of that nature. So, you know, those are the types of things that you're going to be looking at. And your UAP, you could ask them as well, hey, did you see any blood in the stool? Did you see any blood in the urine when you went to the cat? You know, things like that. So these are the types of things that you can ask as well as checking and asking the patient. All right, diabetic, shortness of breath. So maybe metabolic acidosis or is going on with that patient, right? Could be something like that happening. So that's something to bear in mind. What's going on with their blood sugar? For sure. Or is it a situation where they've got an infection and they're becoming short of breath, and we have to look at that? Are they going into DKA? So those are the types of things. Oh, I love your kitty cat, Kathleen. I just saw your cat in the background. Mine, I've got, yeah, one of mine's hanging out here. So, okay, some more delegation pieces. SBAR, nurse to surgeon. Well, you know, again, you need to make sure that you have your ducks in a row, especially when you're talking to a surgeon, right? What's going on with that patient? It could have been, if that patient's just post-op, they've come back to the floor or the unit, they've decompensated in some way. You're going to give a report to the surgeon, hey, there's this, that, and the other thing going on, and I'm thinking that we need to do this. Can I have a standing order for that? Whatever the scenario is, you need to make sure you've got that ready to go, because they're going to be firing off questions at you, and you need to have that sheet ready with all the answers, correct? Especially if it's 2 o'clock in the morning. Let's look at some other things. Rocephin. Rocephin, what is Rocephin? What is Rocephin?
Penicillin antibiotic.
What is it? An antibiotic, right? Is that what you said? Yeah, it's an antibiotic. So it could just be making sure that you know how to put it on the pump properly, all right? How to you know, what rate it's going to go. Is it going to be piggybacked? Usually it's piggybacked, something like that. So it could be something of that nature. So just safety related to those things. Oh, let me scroll down here. Med errors. That's a biggie, isn't it? That's a huge one, especially in leadership, wouldn't you say? It's a big one regardless of where you are, what you're doing. Unfortunately, it happens all the time. It does. So bear in mind your 9 rights, and bear in mind what you would do if there is a med error, you know, incident report, all of those types of things that go along with a med error. And of course, making sure your patient stays safe as well. Let's see, documentation. So it's related to documentation. So I'm thinking if it's talking about a med error, then of course making sure that you document what is going on the incident report, and of course documenting how your patient's doing and what you need to do. You may need to call the physician, well, I'm sure you would, and documenting as well the outcome of that patient. Cushing's syndrome. What is Cushing's syndrome? They look like a cushion. Cushing's.
The buffalo hump.
It's a lot of cortisol being produced. I remember that.
Yeah. So it's an overproduction of cortisol, or, you know, they're either producing it too much, or they're being given too many steroids, or they've been given steroids, you know, for whatever reason, and they end up with this Cushing's syndrome. So moon-shaped face, yeah, all of those types of things, potential for fractures, obviously blood sugar is usually elevated, infection control, a lot of issues to do with Cushing syndrome. So I would suggest looking up the pathophysiology, refreshing your mind on Cushing's syndrome, because it may come up. All right. All right, some other pieces. DNR. What is a DNR? What's a DNR?
Do not resuscitate.
Mhm. So making sure that, of course, when the patient comes in or to whatever environment they're in, that if they have that documentation, that you know about it, right? There's nothing worse than somebody coding and then like, are they DNR? I don't know. Well, didn't you look? You know, those types of scenarios can potentially happen. So making sure that that the DNR is known about, if in fact the patient is a DNR, that it's on the chart, that it's documented, all of the things that need to happen for a DNR, okay? Sepsis, action steps regarding sepsis, knowing what to look for. If somebody comes into, say, the ER with sepsis, by the way, would you give antibiotics first or would you do cultures? Cultures.
Cultures.
Yes, yes. And I don't know that they would ask that, but of course you want to do your cultures, right? You're going to pan culture your patient first, then you can give your antibiotic. And it may just be a standard antibiotic until they know exactly what the culture is brewed. They're probably going to do a broad spectrum of some description, but that's part of your sepsis protocol, isn't it? Fluids, pan culture, those types of things, IV, right? Foley, intake, output, depending what's going on, breathing disorder, I don't know. But the bottom line is you're going to do things like a CBC, comprehensive metabolic panel, right? Cultures, those types of things. Good. All right. Palliative team. Anybody ever seen the palliative team or be involved in that? Do you know what I'm talking about?
You have
No.
more than 6 months to live, but you have a terminal disease, right?
Yeah, possibly, yeah. And sometimes it could be that, I always say palliative is a little bit of that gray area. For instance, when I worked with Select, I was the representative for getting the patient, say, from the ICU to, say, specialty hospital, those types of LTAC environments. Okay, it wasn't specialty, it was actually in Gainesville. But my point is, a lot of these patients were very, very sick, and it was sort of like, you know, we don't know if they're going to make it. Now, they would get the palliative team involved in them because it wasn't as cut and dried as you've got this diagnosis, say, of pancreatic cancer. We know your trajectory is X amount of months and you're going to need hospice, right? But the palliative care team are often involved in scenarios where it is grey or the family doesn't want hospice, but they still need that sort of hand-holding a little bit through the process to get them to hospice. So it's that middle ground. It's the people that can really talk to the families, talk to the patient maybe if the patient's able to, and sort of help them through the process of getting to hospice. That's a lot of palliative care, all right? So you may just want to look up palliative care as a information. All right, delegation. Here we go again. Assignments, delegating assignments, right? Information, and sharing information. So for instance, here's an example. You are having report. You're giving report, one nurse to the other. You want to make sure it's confidential, right? That it's HIPAA compliant, that the whole world doesn't hear what's going on with that report while you're giving it. But assignments as well, making sure that the assignments are appropriate for the staff that you've got. Dressing change, funny enough, has come up as delegation. Can you delegate a dressing change? Well, I suppose it depends on the dressing change, doesn't it? What the wound, you know, how complex is the wound or not? Does it have a wound vac? Does it have things there, for instance, that you actually need a wound care nurse? Probably you're not delegating that. Or if you are delegating it, you don't want to necessarily delegate it to a UAP, right? So those types of things have come up. authority, this is crazy. Delegation comes up so much on this. This is why I'm going over it before we actually dive into chapter 20. Does it make sense why chapter 20 is so important? I mean, I'm going to say half of what this is involved in is delegation. Pain treatment. Would you delegate, for instance, are you going to ask the UAP to go and assess the patient for their pain? What is their pain scale? Is that something that you would delegate? No. All right. And also what treatment? So, you know, again, it depends on what's going on with the patient. It could be a non-pharmacological type of treatment, maybe. I don't know. But again, you're going to be careful as to how you delegate pain treatment. Fire alarm. Fire alarm came up. So make sure you know your RACE protocol. You know, you might not have to know that, but you certainly need to know that there is a protocol for each hospital and each environment when the fire alarm goes off. You know, are you closing all the doors, for instance, to all the different rooms, those types of things. Let's see. Preventing litigation. We talked about legal a little bit, I think, didn't we? A little bit? Legal aspects. You know, one of the ways of preventing litigation is how you talk to your patient. You can make or break a litigious situation, by the way, with how you communicate with your patient and their family. That is huge, by the way, absolutely huge. I know myself, I've had scenarios where even recently, you know, people are maybe not happy, but they may not be happy, but they're happy with the care. They're not happy maybe with, say, whoever talked to them on the phone at the front desk, or they're not happy about some, I don't know, office management stuff or whatever's going on, but they're really happy with the provider and how you cared for them. And that can make or break whether they come back to my office or not, right? So the same with litigious situations. They may have had a situation occur where they may want to sue, but because of how you talk to them in a management role, or because of how you handle the situation, transparency is one of them. You know, I really know how you feel, or rather, you know, I want to understand more about how you feel. Tell me more about that. Help me understand. Open-ended questions, all right? That can make or break a litigious situation and prevent it, okay? Med errors, again, coming up. 9 rights. Know how to manage your med errors. What are you going to do as a leader? How are you going to handle it? Incident reports. What type of things are you going to do to mitigate it? Case manager, what their role is. Delegation of care. Again, how do you delegate care? I mean, it's just on and on and on. Follow-up questions, like I just said to you. When you're teaching and you are asking, say, for a teach back situation, you might need to ask more follow-up. You know, did you know how to do that? Do you understand what's going on? Do you understand how to manage that? What's your home situation? I don't know. But the bottom line is it's not just a sort of, okay, off you go. You need to follow up, follow up, follow up, follow up. It's huge. Now this is an odd one. Gunshot wound and pulse oximetry. I don't know. I'm not sure where I'm going with that one. I mean, you know, I would think they need a bit more than pulse oximetry with a gunshot wound. I can't help you, but depending where they got shot, I don't know. Oh my goodness. Make sure you use a pulse oximetry if they've got a gunshot wound. That's all I can tell you. I'm sure there's more to it than that. I'm sure it's something to do with O2 sacs, respiration, and maybe ABGs, I'm just going to say. But I just found that, like, of all the things, pulse oximetry. Again, assigning nurses. So again, delegations come up again. It's sort of ironic to me. Delegating glucometers. Can a UAP do that? As Tiffany was saying, she was able to do that depending on where she worked. So that's a big deal. And it may say the patient works, say, in the hospital environment, and that's their policy, that they can do glucometer checks. And we're going to actually look at one of the case studies related to that. Diabetes. Looking again at assigning care. Meaning, well, one of the case studies that we're going to look at actually looks at unlicensed personnel even giving insulin, but the insulin is pre-drawn up and everything is ready for them. I'm not saying that that's what the question's asking, but definitely being aware of all of the pieces with diabetes. What are we looking at? We're looking at foods, right? We're looking at their signs and symptoms. We're looking at patient teaching. We're looking at glucometer control. We're looking at hyperglycemia, on and on and on. So there's a lot of pieces with your diabetic head-to-toe assessment, on and on and on, that we could look at. I don't know what they mean regarding the assigning, but be aware. Pain medication assignment. Pain meds. So controlled substances, right? That would be a big deal. Making sure that, of course, if you're giving controlled substances, making sure that you're checking that you have the right count when you come on and when you leave. Yeah, those narcotics, that's a big deal, isn't it? Let's see. Living will. Living will. What's a living will? Anybody know? I think we talked about it. I thought we did.
It's an event if the people say what they want to happen in the event that they can't make decisions for themselves.
Exactly. And I don't know about you, but I've seen numerous times where patients have a living will and they can't speak for themselves, and the family members just trounce all over it and say, I don't care what mum said she wanted, we're going to do this instead. We want to keep her alive, right? Anybody had those scenarios or been around those types of scenarios? Maybe you have, maybe you haven't. But living will, especially no heroic measures. No, I don't want to be on a ventilator. No, I don't want this. No, I don't want that. So we have to make sure that we abide by what that living will wants. But as I say, it does tend to get into murky waters for sure. There's lots of ethics. I've been involved in a lot of ethical meetings and conferences related to living wills and family members not wanting to adhere to them. All right. How are you going to chart a missed prescription? Or again, how are you going to document a missed med? Or maybe the script is missing, the actual prescription. Maybe the script got written and the patient doesn't have, it may have been a hard copy script or something, and the script got, especially if it's narcotics or if it was an amphetamine. Yeah, that's sort of a big deal, isn't it? Those types of things. And I'm not saying that that's what it's asking, but we have to be aware of those things. Oh, I mislaid my script. Really? You did? Really? Where's it gone? I've had those scenarios occur working in doctors' offices. Guess what? I can e-force you and find out where that script is. That's for sure. How many scripts are missing and how many scripts are out there? All right, endearments. This is actually a big one. Do you know what I mean by endearments? What do you think that means?
Is it like an inappropriate relationship with a patient?
Well, that's a good point. Even if it's not an inappropriate relationship, an inappropriate, for instance, so we're in the South, right? And people tend to say, how you doing, honey? You doing all right? Or though I'm just using that as an endearment. That's an endearment, for instance. Now, that might be okay, but depending on the population that you're talking to, an older generation, something like that, depending on the working relationship that you have as well at work. So, you know, we have to be careful, and we have to use professionalism when we use what we consider an okay term and what may not be okay. I know, you know, my mum, for instance, she's in her late 70s, and she can't stand it when she goes into a shop and people will say an endearment like, how you doing, love, or whatever. And that's a British way of saying, you know, she doesn't like that at all. And I think a lot of elderly people don't like that. So it is something, again, to be aware of. And I go back to that sets up the stage for that working relationship with these patients. And, you know, then they get annoyed about something, and all they remember is that nurse came in and she just called me love all the time and I hate her. And then it spirals into some, you know, horrible thing where they don't want you looking after them, and on and on and on. So bear in mind those types of things, and I'm not saying that that's what it is, but just be aware of endearments and how they can come across. And then finally, teaching, RN teaching. So I'm not sure what this is related to. It's talking about depression and grief. So it could be, again, teaching and understanding what's going on with that patient, or you could be teaching another nurse. You could be teaching the depression scale, right? Knowing what to look for depression, the signs and symptoms, knowing if somebody is suicidal or homicidal, all of those types of things. Okay, so I hope that gives you, I feel like we went through that fairly quickly, but I think that gives you definitely an understanding that the majority of what we're talking about here is delegation. Let's see if there's a couple of other pieces, by the way. Meningitis came up. Anyone know what meningitis is? What's
Spinal.
One's bacterial, one's viral.
Yeah.
Right?
Yeah, inflammation of the meninges, yeah? So we're looking at maybe increased intracranial pressure. That could be partly what we're looking at, okay? So I would definitely look up meningitis as well, and SIRS, which is systemic inflammatory. I think I put it on your announcement, SIRS. So, and another one is all AKI, acute kidney insufficiency as well, knowing what you're looking for. So what type of labs would you be looking at for acute kidney insufficiency?
Creatinine.
Mm-hmm.
BUN.
BUN. Yeah, BUN, creatinine. What could you delegate to your UAP related to that, by the way? Kidney. What could
Monitor
they?
eyes.
Collect the urine.
Yeah. Monitor the urine output, depending on what's going on, right? Again, I mean, you know, if it is an emergency type of stuff, maybe not. You know, they may have a Foley in and you're monitoring that stuff every hour, maybe not. So again, that's when you have to use your professional judgment and decide what you want to look at. Based on that as well, a nephrectomy care, nephrectomy. Okay, so post-op care of a nephrectomy might be something that you need to look at. Post-op bowel as well. So that gives you a little bit of an idea, and I'm sorry that I can't be more detailed about that. Is that the type of thing you've been given before, that sort of information, or is that more or less, or?
It's about the
It's about
same.
the same. It's about the same.
Okay, good. Well, then that's good. I just want to make sure I'm on the same track as what you have been given, be sure. So, all right. So with that, let me close this out a second. And
Miss Fletcher,
yeah.
what about employee support?
Employee support, I really, you know, what I'm thinking is something like employee assistance program, but I'm guessing, you know, it could be the employee assistance program, things to help the employee grow in their professionalism, for instance, as well. It could be that we're giving CEUs or helping them to go on courses, helping to develop their where they're working. So that's I'm not sure what they're asking for that. So it could be something along those lines. But professional development might be part of what the employee support is. Also, it could be to do with staffing, right? It could be employee support related to that. I know that's a biggie. Making sure the employee feels heard, you know, if they've got a grievance or a complaint, helping them understand where they need to go for complaints, such as compliance, those types of things. So I don't know what they're asking in that line at all, unfortunately. So they do make it a little vague, but I think you guys will do well. So let's do this. So I did sort of mention to you that delegation flow chart that is on page 349, okay? And what we're looking at are, first of all, are there laws? What are the laws? What is the Practice Act? What is it that they can and cannot do related legally? Is that within the scope of practice? Have you assessed the patient? Yes, I have. Great. I've assessed the patient and the skills, the things that I'm asking the UAP to do or the other person to do are well within their scope of practice. And remember, it's not just unlicensed. It could be that you're in charge and you're delegating care, okay? So is it going to be performed with a predictable outcome, meaning, you know, bathing, you know, that should have a predictable outcome on the whole, as an example. It doesn't endanger the patient. It doesn't endanger their life. Let's see. Does the UAP know what they're doing? Are they able to wash the patient and clean them? Do they not only have the skills and ability to do that? You know, do you potentially need two people? Is it a very large person that maybe needs two people, right? And do they know how to roll a patient and change the bed and all of those things? Be aware of the agency protocols within that particular agency. What is okay to do? Like you said, Tiffany, in the hospital, you could do glucometers. In the environment you work now, you can't. That's an agency policy. That's their own policy. And anyway, and then supervision as well. And so the other thing I want you to be aware of are the standards of professional nursing practice. And again, that talks about you as a nurse understanding, doing that initial nursing assessment, understanding your judging and skills and everything that goes along with it, and then going, yeah, they can do this, or yes, they can do that, or no, they can't. So know your patient, know your staff members, know the tasks, explain the tasks. You might have to explain it to them. They may not know what you're talking about and what is expected as well. And I'd say that's a biggie. Expected outcomes, what is expected from that task that you're going to be able to do. Hey, I need you to take the blood pressure and report back to me. I need to know whether the blood pressure is higher than 140/90. So you might have to be really specific in what you're saying, right? Expect responsible action from the person that you're delegating. Hey, when you've done this, that, and the other, I need you to come back and report back to me what happened. Assess them. Assess and supervise them, and then evaluate. And also there's another piece of it, high risk delegation that it talks about on page 353. And then there's steps to remember as well. Remember, we need to document, all right? So whatever they're doing, again, I'm picking on Tiffany just because she's mentioned a few things. She checked restraints, but she didn't just check them and walk away. She had to chart, right? She had to put a check mark on or whatever it was to say that she had done that task. And obviously we're going to be responsible at the end of that shift to make sure all of that is done. There is on page 354, and I'm sorry that I'm using this rather than the PowerPoints, it's just that I highlighted when I was going through it. It's the 5 rights of delegation. And again, and the reason these things are important, we're going to do some of these case studies and we'll go through some of this, the right task, the right circumstance. It's a bit like the 9 rights medications, direct communication, the right and direct communication, the right supervision, and the right person. So on page 354, the 5 rights. I would say those are very important pieces, and they're going to tie in nicely with your HESI. How are we doing for time? All right. Let's see where I want to go with this. I think there was just a few more things. Yeah. On page 356, there were a couple of other pieces that I wanted you to look at as well. And again, it could tie into the HESI. I'm not saying it will, but remember we were looking at infection control. So making sure that your UAP understands infection control. Are they gowning up and gloving up? Are they doing the right things when they go in that room? Are they, you know what, I remember it now. The student nurse went in a patient's room with contact precautions and came out of the room fully garbed up. Is that appropriate or not? No. You take everything off before you come out of the room, right? So that's the type of thing that you need to make sure that when you're delegating, that they understand that. And to your point as well, Janie, that employee, I can't remember the terminology, but basically making sure your employee is given all of the right tools so that they don't make mistakes, right? That's employee teaching when they come on board, so that we do these employee, when they start a job and they know what is expected of them. So anyway, what technology is involved. For instance, if you go in the ER, the techs there are able to do a ton of stuff that you normally don't see on the floors, right? They know how to put an EKG monitor on. They know how to do all sorts of things that maybe you're not doing on the floors. They know exactly how to do it all. So that's something that you need to be aware of. And it says here, does the patient have multi-system involvement? And that could be multi-disciplinary involvement, right? As well as multi-system. Infection control, so a patient comes in with night sweats and a cough, the cultures are pending, and then there's the next patient next door who's having chemotherapy. you might not want to cross-pollinate those two, right? For sure. One's neutropenic, one might have either pneumonia or even TB or something. So again, understanding room designations and understanding as well how you're going to delegate what staff member goes where. And then finally supervision as well. So it might be an RN. You could have 2 RNs coming on. You might have someone like myself who has, 40 years of experience, but I haven't worked in, say, an acute care bone marrow transplant unit in many years. And I might just be PRN as opposed to, say, a nurse who is 5 years in. She's going to be much more savvy in some ways regarding to what's going on that unit than I am. So again, making sure you delegate the right patients. Okay. So those are the things for chapter 20. And it's not a very long chapter, but from my perspective, from what I saw on the HESI, I would say it's a really important chapter. So let's just give me a second here. I'm going to minimize this and pull up. Let me ask you, did you have any problems with the other team links, or did you not try them, or did you just try this one?
I only tried this one.
Okay.
Tried this one too.
Yeah.
Same here.
Okay.
Can anybody hear me?
Yep,
Oh, okay.
I could hear you. So we'll do a couple of these and then we'll have like a 15-minute break. And then, as I say, I've got a few more case studies for you that I want to do, okay? That we'll keep going. So I have, seeing as though acute kidney injury is something that possibly is going to come up on the HESI, I thought we would do acute kidney injury as a case study together, first of all. All right. Give me a second. I was just pulling it up. Find you guys. Screen share. How's your week been? How was clinicals, by the way?
We didn't go this past weekend because of the fourth.
Were you supposed to go or not?
We were supposed to go Saturday, but they postponed it. They switched it to the 8th of August.
What?
Yeah, they switched it on us. I guess because of the holiday. I guess they didn't have enough staff at Kindred.
No, they didn't think that we had any clinical instructor. So it was a miscommunication between Barnhart and Molina. And Molina kept telling the staffing that she was there for us, but they just went ahead and rescheduled it because Minwar was on vacation.
So help me understand. So Miss Barnhart and Miss Molina?
Correct.
Okay.
So those are our clinical instructors.
And they, because
it was just a big miscommunication. Molina was there, but I guess they forgot that she was there or that she was available. So they just thought we weren't going to have a clinical instructor. So they just rescheduled everything.
Oh my gosh. Oh, wow. No one told me that. That's so. Are you due?
Well, they didn't even tell Molina, because Molina is the one who she messaged me at 9:00 at night on Friday, telling me to message the group and let them know that we were meeting at Kindred. And then I called her and I said, no, we were rescheduled for it. And that's when she had to call Minwar. Like, we sat on the phone for 45 minutes trying to figure out why no one told her that our clinical day got rescheduled. because she was still under the impression that we were supposed to show up last Saturday.
Oh, wow. Okay. So let me ask, are you going this weekend or not?
Yes.
You are. Okay, good. Wow. Because we're like in week 5, right? So I don't know how many clinical weeks you're going to be able to go there, but you definitely need some experience for sure.
So did anyone mention to you that we're missing 8 hours?
No one has mentioned that to me at all.
Okay, so we spoke with Burles yesterday because now she's our new teacher for the other class, and we're missing 8 hours for this class for clinical hours.
For transitions, you mean?
Yes, ma'am.
I emailed Miss Fletcher. I sent an email to you and Miss Minworth both at the same time last night.
I saw an email about it, but no one has said anything related to that. I'm at the college tomorrow, so I'll try and understand a little bit about what's going on, because I don't know quite how you would make up 8 hours clinical. I'm not sure. I mean, or even if you have to, I'm not sure about that. Who told you that you were missing it?
Well, technically, we had a Friday that they put on our schedule, but we're night classes and they wanted us to come for the day. Well, then they came back. Minwar was like, oh, it's optional. You don't have to come. Well,
Right.
they didn't filter out the fact that they marked that as a clinical day. So now we're missing out on those hours.
Okay. Well, I'm sure they'll figure something out. So tomorrow, I wondered what that was about. And no, nobody has actually discussed that with me. But let's see if I can talk to Miss Minwar tomorrow and clarify that for you. Okay. And we'll get that sorted out. All right. So let's look at this. Can you see this, guys? This case study right here? I figured this would be a good one, seeing as though potentially that's a HESI thing for you, right? So let me do this. I don't want, actually want that. So let's look at this. Can you all see it? You can? Is it big enough?
Yes.
Okay. So you are the charge nurse. Patient's got vomiting and diarrhea. He's got a fever, tachycardic. Ooh, I don't like that blood pressure. Do you? What do you think of that blood pressure? So what are you going to do? It does tell you. I'm trying to hide it. What would you do?
B as in boy.
Anyone else?
I agree with Tim.
Any others that you would do first? Thinking first. B. I mean, look at this blood pressure, right? You got to get that pressure up for one thing. I mean, the patient's been having vomiting and diarrhea for 2 days. Obviously, they're dehydrated. Let's look at this for a second. I mean, yes, you can give Reglan, great. And they've already been vomiting for 2 days, so that's a good thing to do. But you certainly want to get these fluids in them. You do want to draw blood. But think about it, you want to do a CBC in chemistries, but remember they've got some sepsis going on. So you want to do cultures as well. That's another piece of it that's sort of missing here. And while you can give the Tylenol rectal, I mean, that's fine. But I would give that once while I've got this going, because if you're giving it rectal, it's not like it's going to have an immediate effect anyway. It's going to do that first pass effect. It's probably going to have to go through the liver. So it's going to take about 20 minutes before it even starts having an effect, right? So that's how you would prioritize that. Okay, let's look at this one. So this patient did come in with dehydration. And what are we looking at here? Ooh, what do you think's an issue?
The potassium.
Yeah, I do not like the look of that potassium. Do you? Is that normal potassium?
No,
No.
it's too high.
Yeah, way too high. Yeah. Okay. What's the issue here?
See?
See?
I think C. What about that heart rate? This is a huge issue. Well, I'm curious, what made you choose C?
Oh, just the confusion.
Confusion part.
But would you consider that most important?
No.
Okay. I mean, this is all part of the same case study, right? This is all part of the same thing. So we know that this patient's potassium was 7 point something. So we know, we know from the work that we've done previously, looking at adult health 1 and 2 and all that sort of stuff, that when you've got a potassium either high or low, doesn't it have an effect on cardiac function? I mean, it has an effect on everything, but something like a prolonged QRS duration could, heart rate's dropping down to 46. Ooh, they're in heart block. That's a little bit of a concern right there. Okay. All right. So, we don't like what's going on now with this patient. Let's see what else is going on with them. Oops, I'm sorry. Remember that potassium? What do you think he might do?
C?
Yeah, I'm thinking C. Let's see if it's right. Oh, it's B, calcium chloride. Okay. So you do need to do K-exolate, but it's going to take a lot longer. So apparently calcium chloride first to bind it, to shift. Let me pull that up so that you can see that a bit more. Hang on a minute. There. Can you see that response there?
Yes.
Okay. So it's going to shift it where it needs to be, hopefully correct the bradycardia, but you do need to give that K-exolate as well. So that would be the second thing. Okay. All right. See what else we got. So they're having CRRT. I think that's supposed to say CCRT. Okay, hyperkalemia. They've got continuous dialysis going. Here we go. What action will you delegate? What are you going to do? Oh my goodness, people, leave me alone.
You can delegate the obtaining of the blood pressure and the urine output hourly.
What else? Maybe. I'm
D.
not sure about this. What about this?
I think they can.
Definitely E, but not.
Mm,
Yeah.
I
They
would
might
say
do
that.
this.
The electrodes.
Yeah, they can do A.
They're not going to be doing that. They're not going to be doing this. This is assessment. This is assessment, right? Possibly this. So maybe
A
A.
and E.
Maybe, let's see, A and E. There you go. Okay. 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 All right, so the patient is now diuresing. So let's see if they give us any information about this first of all. Yeah. So I'm going to pull that. Did you read that? Did you look at that, by the way?
Yes.
Okay. So let's just look at some of these important points. And I don't know if you can see this. I'll try and make it bigger. Can you see all that or not? Let me know. Okay, good. So yeah, we've got a few issues. I mean, if they're potentially putting out 3 to 5 liters a day while they're diuresing, that's a heck of a lot of fluid that we have to manage, right? And make sure that they don't then become completely dehydrated. So, that's going to be part of the plan that you're going to look at. How are they going to remove some of this metabolic waste? You're going to check on their cognitive function, right? There still might be issues with that. Electrolyte balances as well. Hyponatremia, hypokalemia. So then, unfortunately, if they're going to have low sodium or low potassium, again, you're going to have to look at cardiac changes, possibly. These are the types of things you want to make sure. Again, if they're diuresing or if they've got fluid excess, where could that fluid excess go? What are you going to assess?
Long sounds.
Yeah. What else?
The legs for edema.
Yeah, peripheral edema. Even possibly ascites. They may have dependent edema. Things of that nature. Pericardial rub, meaning, there's fluid around the heart. That could be an issue. Weight monitoring. That's something you could potentially delegate, isn't it? The weights, daily weights. Okay. So it's a few different things related to acute kidney insufficiency. It's not a small thing. It's a pretty big thing, isn't it? This, I would say, is a big deal. This acid balance control, because if we don't have that in balance, as soon as we've got something out of balance there, metabolic acidosis could occur, something like that. Okay. So we have quite a few things there. All right. So that might be just helpful for you to sort of get your brains thinking about acute kidney insufficiency, because I say that potentially is going to come up on the HESI. So I do want you to be aware of that one. All right. Would you like a 15-minute break? All right. So it's 20 past, so I'll see you at 25 to, and we'll do a couple more of these, right? Okay. All righty. Is this helpful doing some of these case studies? Good. All right. So let me share my screen. Okay, so I figured again, as I say, I've tried to pick out some case studies that are hopefully going to tie in with the study that you have for Hesse. Come on, you coming in? No, she's not. All right, let's look at this one. Perioperative care. So I know a lot of it was post-op, but unfortunately this was all I could find. So, but at least it's along the lines. So let's have a look at what it says. So I'm going to let you look at that for a second. Go on out. Did you read it? Okay.
D. No?
Yeah, it's got to be D, isn't it?
I think so.
Yeah, I would say D. Hang on a minute. Let me. Oh, A.
Oh, oh
What
because
thing?
of latex.
Of course. That
Oh,
makes sense. Duh, I wasn't even thinking about that. Mm-hmm.
Tiffany keeps getting kicked out, so she just wanted me to tell you.
Okay.
She keeps coming back in.
Yeah, I can see.
Okay.
So A, latex allergy. Uh-oh. I wasn't thinking about that. I should have looked at that properly. That was, see, that's what happens when you don't read the question properly. That was my issue. All right, so if you see something like that, you know what to think. And look, it's your first assignment, right? So if she's saying she gets a rash, that should be a. All right, let's look at this one.
Her BP's high.
Not really.
No. Okay, so then I want to say D.
This time it is D.
Okay.
I think actually what happened with me, I'm sorry, I'd actually looked at these and I recall, but yeah, it's got to be D in this one. It has to be, yeah. And it goes to that informed consent.
Mm-hmm.
So that's the thing with this, all right? So this is not really, I mean, yeah, he's going to have knee pain, right? He's having a knee replacement. Cup of tea 3 hours ago. It's probably not going to be a big deal. But yeah, if you're saying you don't need the surgery, then you need to stop everything for a minute, call the surgeon, find out what's going on, find out why the patient doesn't feel he wants it, and on and on and on. All right, so the surgeon might need to come up and talk to the patient and clarify some things before the proceedings. So that's the issue with that one. All right. What are you going to delegate?
A,
B.
A, B, D. No, not D. A, B, and E. I can't see the rest of them.
You can't see all of it, really?
Hold on. No, it's mine. It's mine.
Oh. You want me to read it? Can you? It says the last one is informing the OR staff about patient
Okay.
allergies and
Yeah,
current.
it'll be A, B, and E.
I would think yes. I'm not sure about B, but it is A, B, and E. There we go. You got it. All of the others are more assessment skills, really, aren't they? Okay. Obviously, this you can't. This is assessment. All right. Now, this one you may or may not get. This one's a complicated one.
B.
B is in boy.
Yeah. Yeah. So this is a complicated one. And now a couple of things. Succinylcholine. By the way, this is the one that is used when you're going to anesthetize when you're going to do intubation, by the way. This gets used. Choline, it upregulates acetylcholine. So it's a cholinergic medication, first of all. Let's just look at it. Even if you didn't know, let's just look at it a little bit. Is that a big deal? No, completely not. So we can eliminate that. Is this a big deal? No, that's not. So really we're looking at this one or this one, right? The patient doesn't respond to painful stimulus. Well, okay, you're assisting the circulating nurse during an abdominal surgery. So they're in surgery anyway. I'm hoping he doesn't respond to painful stimuli, right? I don't want him to, quite frankly. So the only one, even if you didn't know, really the only one it can be is this. But here's the rationale, and I'm just going to show you. It is B. This particular medication can actually cause what's called malignant hyperthermia. Now, the issue with malignant hyperthermia is some of these things, trunk and extremities become rigid. There's a lot of it, and it's a rare side effect, by the way. It's malignant hyperthermia doesn't happen a lot in the OR, but it is one of those things that they say, always assess your patient for malignant hyperthermia. So this is one of the issues. Now, this is what you would do. 100% oxygen and dantrolene. That muscle rigidity. What happens with acetylcholine? And if it helps you, I always go back to my Parkinson type of patient. You know how those Parkinson patients look? Very sort of rigid movements. You know what I'm talking about? Well, that's because there's too much acetylcholine and not enough dopamine. So when you see things like this type of med, here's your clue, choline, all right, acetylcholine. So that was a hard one, but if you actually do elimination, it's the only one that could be correct. So just took a minute, that's all. Okay. Which order would it be in?
Would it be D, A, DACB.
Think of your ABCs.
So, A.
So think of your ABCs. Remember gunshot wound with the pulse oximeter,
Mm-hmm.
right? Your ABCs. So what would be first?
C.
C. Then what's next?
A.
Mm-hmm. Then what's next?
B.
Correct?
And then D.
Correct. Yeah. So you've got your airway, your blood pressure, circulation, and then that. So let's just have a look at the priority. C, A, B, D. Okay. So always look at oxygenation first. And as I say, I don't know what that HESI question will say, but the point is it's a gunshot wound and they're asking you to look at the pulse oximetry first. So you're always going to look at your airway first. Okay. All right. And of course you want to look at, incisions for bleeding and swelling. They've just had surgery. Okay. And if they've just come out of the post anesthesia, well, they're still coming around anyway. So I'm not saying that's not important, but it's talking about the order of importance of what you're looking at right here. Does that make sense?
Mm-hmm.
Okay. Okay. What do you think?
B, C.
I'm thinking C too.
It's got to be C. Again, thyroidectomy, right? Rests are 10. That's not particularly great, isn't it?
Airway obstruction.
You've got to look at airway first, always. Yeah. Okay. All right. Good, good, good. Okay. So this is looking at what? What information? Again, on the HESI, what did it talk about? How do you delineate information? How do you transfer information from one unit or one place to another? What do you do?
S-bar.
Thank you, S-bar. Exactly. So how are you going to organize that information? Let's look at this a minute. Can you see that, guys?
Yes.
Good. So look at what it's saying. Situation. Hey, I'm blah, blah nurse. I'm wherever. This is the patient. They're ready. This is what's gone on. B, you're going to do diagnosis. They had purulent drainage. What type of anesthesia? Vital signs are good. Pre-op, post-op, H&H. Labs. They've got an elevated white cell count because they've got an infection. Their medical history, whether they're, allergies, all of that sort of stuff, right? Medications, what meds you've got them on. A, vital signs, SATs, pain level, definitely. Are they alert? What the wound looks like? IV fluids. INOs, do you have any tubes, lab results, all of those things, right? And then finally what you would recommend. And you would always do this as well at the end, right? You have any questions? Not you. That's what I would say. You have any questions? Because they might. Right. Well, yeah. Before you send them, I just want to make sure there's this, that, or the other thing. Is there family? There's always a question, isn't there? On the whole, it's never like, okay, right, bye. So that's a pretty important thing as well you're going to ask. Okay. Your SBAR. So I would definitely brush up on the SBAR. I probably need to brush up on the SBAR too. But anyway, so is this helpful doing this? It sort of ties in, doesn't it, with what you've got to know. Yeah. There we go. Let's do that. There we go. All right. Let me close that a second. Let's see. Let me look. I've got a couple of other ones. I was originally thinking of splitting you guys into 2 groups and doing this, but I think we'll do the whole thing as one whole group. It's probably just easier to do it like this and get some questions this way. The next 2 we're going to do, and then this final piece that I have is more of a discussion, all right? So, but it's pertinent again. There's a lot of pieces in the final 2 case studies that I'm gonna do. All right, what other ones did I want? Okay. Let me look at this one. This is the type of thing that comes up for sure, I would think. But again, I don't exactly know. Can you see that one? Pediatric asthma. All right, let's look at this. Okay. So this is an experienced LPN working in the clinic. So what do you think you could assign her? Pretty much all of them, I'm thinking. What do you think? Shout out some ideas.
BC, how about like B, C, and D for sure. An E, I mean.
Well, definitely, I'm thinking E for
Yeah.
sure. This one, I don't see why not. I don't see why this would be an issue.
Why not A? I mean, they can't.
I did. Yeah, I mean,
Yeah.
that's what I'm saying. I don't really see the issue with any of these being an issue for the LPN, quite frankly. especially, they need a nebulizer. Okay.
Mhm.
Persistent asthma. They've not been using their flu. Let's just have a look at this one, because if I can open it up, I will. Okay. Only A. So you could do A
Oh,
and C.
the one I thought maybe not is the one that you definitely could do.
So this is interesting, right? So I don't know if you can see this. Let me show you. So again, this whole delegation piece, what they're basically saying is A and C. So yes, those are sort of, in their eyes, straightforward. Hey, this is what's wrong with the patient. But the other issues are more teaching, a little bit more involved. They're more critical thinking pieces. Now, I know incredibly experienced LPN that have trained me when I was a baby nurse, basically. So can they do it? Yes. But I suppose what it's asking is that the right thing to do? The RN is the one that has this critical thinking piece, has been taught how to negotiate and navigate teaching and all of those pieces. Patient education, parent education, obtaining health history, blah, blah, blah. So really they feel that should be done more by the RN, whereas I know it's sort of interesting because, obviously this one just needs a nebulizer and this one's doing skin testing, but these are the ones that have a little bit more assessment to them. Okay? Interesting, isn't it? Come on, you go out too. Come on. Excuse me a minute. I'll get rid of my big fat cat. Come on. Go on, out. Thank you. He's like a Pooh Bear. He actually is like Pooh Bear. He's like, just give me honey and I'll be fine. All right, so let's look at the next one. You assess the child has not been using a Flovent inhaler. Which teaching point is the most important to stress with the patient? So again, a lot of teaching, and that comes up on this HESI, right? What are we trying to do with Flovent, by the way? Is Flovent used as a PRN type of inhaler or not?
I thought it was preventative. Am I wrong?
You're correct.
Okay, so I was gonna say B. I'm guessing no one else is helping. Hello?
It's B. Good job. It is B. And that's the key piece, right? It is an inhaled corticosteroid. And the reason I brought that up about it not, that's where I was going with that. It's not albuterol, right? So albuterol is the only one that you're going to use when someone is having an asthma attack and they need their albuterol inhaler. You give that first and then you give your steroid, don't you? So you give the albuterol to open things up, and then you give the Atrovent or the Flovent or the inhaled corticosteroid to reduce what? Inflammation. Okay, that's the process. So the whole point of this is preventing those systems, suppressing that inflammation. That's what you're trying to do here. Okay. All right. How are you going to test whether asthma is possible? What's the testing that you're going to use?
The PFT.
Thank you. Pulmonary function testing. Oh, it says it right down there. But anyway, it is. It's pulmonary function testing. Now, the other things are useful. You know, it's nice to know what is causing the problem, right? What IgE issue is and allergy testing, those types of things. But pulmonary function is what you're going to do. All right. Come on. There we go. Okay.
D is in dog.
Yeah. And that's what I'm thinking. Don't like those peak flows, but let's actually see. Oh, okay. So I didn't read the question correct. Did anybody else read it correctly? Did you pick C? You did? You didn't say it. Why didn't you say it?
Because I'm eating my chicken.
That's funny. I actually did not read this. So here's the key. 12-year-old with mild it's mild, but he used all of his prescribed rescue inhaler. And this is peak flows, obviously not SATs, but even so, I don't like that it's dropped, but that really is the big issue. That's hilarious. So let's just have a look at this, right? So by the way, an 80% with the peak. Does anybody do peak flows? Is anybody an asthmatic who does peak flows? So apparently this is still in the green zone. Green is fine. So that is the issue right there. They used also, they've been taking tons of that inhaler. Not good. Not good. All right. Oof, I don't like that.
A.
Yeah. A and then B, I would think. Well, A. Get some steroids on board as well. But you always want to bronchodilate them, right? Let's see if that's, yeah. So you got to do this first. Got to open that airway. So it's got to be albuterol. Always think of your albuterol as your bronchodilator. That's your immediate response thing, immediate response med. Okay. I can't. Are those frogs somewhere there, or is it here? I can't think. I can hear some frogs.
Sorry.
Is it you? Oh, okay.
Is
Is it where you live? Okay. There's a lot of we have them out back, but I have them a lot out front too. All right. So what do you think?
and decreased breath sounds.
Well, we don't have any wheezing. Yeah, I don't like the sounds. I don't like that pulse either.
I'm thinking B as a boy.
The pulse can go up if you get albuterol.
Well, that's true.
Good job,
So,
Riley.
this is what it's showing. Absent wheezes and decreased breath sounds. So, you know, again, we're looking at our ABCs. I suppose we always have to go that way. Little bit confusing because when we started out, let me just see at the top here. Did it talk about this person, this young kid? Where is it? The 12-year-old, right? This is where we're going with this 12-year-old, used all of his inhaler. Then we see this 12-year-old again. Okay, he's got the rate of 40 retractions, and he's got the inspiratory and expiratory wheezing. We give him the albuterol, and this is the response. He's now got absent wheezing and decreased breath sounds. So, yeah. This is going to go up because of the albuterol. All right, let's look at this one. So what do you think are some of the important teaching points for asthma for the family?
Keep the rescue.
Rescue inhaler.
Identify.
Maybe look at what the triggers are. Yeah. Patient triggers that trigger the trigger any of the issues. As you said, making sure they always have their inhaler, the rescue inhaler around. I would say as well, we said about the triggers, making sure they know how to give it. She might need a spacer, right? That could be part of the reason that she ended up with status asthmaticus in the first place. Maybe they weren't using it properly. Maybe they need a spacer. Making sure as well, peak flow monitoring. Okay, peak flow monitoring here. Knowing that, and you might want to look that up if you haven't looked at that in a long time. Looking at the different zones, the red zone, the yellow zone, and the green zone, the different zones for peak flow monitoring, because they have to monitor this, right? Usually as well, you have an asthma management plan that the patient and the family follow that indicates if the asthma is worsening or not. So those are the types of things. Medi-alert as well. So I would suggest you relook at your asthma. I know in 1640 they go over it a lot. Correct? 1641. I don't know if you go over it again in some of your other classes, but definitely I remember going over this a lot. So I know there's a lot of information there. But here, teaching points to help prevent them from that happening again. We always want to look at preventative care. All right. I have one more of these and then I've got a couple of others. All right. So hopefully this is just giving you some help to sort of hone in and focus on what you want to focus on the HESI. Does that help you a little bit? Okay. And seeing as though this came up, I thought this would be a good one to do because this term came up as well. Okay. All right. So let's look at depression because that came up a little bit, I think, with patient teaching and certain management roles and delegations. So let's look and see what this one says. What did I say about open-ended questions?
See,
Possibly, right? You know, on the whole, you always want to. The other thing, like, you know, we're presuming on these other things. I mean, I'm thinking C. Yep, C. Because we until we ask a question, we don't really know what the problem is, right? We don't know if it's that he is tired, distracted, or disinterested, or is it that he wants to go to the bathroom? I don't know. But until we ask a question, we are not going to know. You stay out. Can you let him out, please? Could you let him out? Thank you. What do you think?
B.
Yeah. B. As I say, these types of things are always looking for the open-ended question, right? Is that what you all thought, B, by the way, or were you didn't know? You didn't know. You're like, I don't know. Who cares? You are old and fat, and we don't care. Is that what you're thinking? Open-ended questions. Have you been hearing voices?
Would it be A, C, and F?
I don't know. Let's have a look. You did well. There was just
I thought about B, but I wasn't sure.
yeah. I don't think this would be appropriate,
Nope.
right? But the bottom line is, as I say, we've got to look at these might be questions that you ask, but it's more to do with you're concerned with his mood right now. So if we're looking at the mood, this is why those are the appropriate questions, because that's what we're focusing on. This is more discharge planning to me. That's a discharge planning. This is more of a medical type of question. So, okay. All right. Is this helpful a little bit? Just to go through some of these? Yeah.
A.
Would it be D?
Let's see, assessment API, right? Assessment, intervention, and evaluation. Yeah, that's what I was wondering, whether it was C. Because I look at it this way, and it's, you know, we're a nurse, so we're not actually diagnosing. Now, we can use a nursing diagnosis, but we can't actually diagnose. So that's why I was wondering about that. But let me just see their rationale on this one so that we can look. First, use the nursing process to identify problems that you can address. The other options are part of the whole care. So yeah, we think he's depressed. I'm sure he is. We could call the doc and say, hey, we think this person is depressed. But before we get this antidepressant on board, there's a few steps that have to be done to get that, right? He has to be evaluated a little bit more than that. So anyway, so identifying some more information, more nursing diagnoses. Okay. Uh-oh, I don't like B.
B, D, and E.
Well, definitely B and
I
E.
didn't read all of D.
I'm wondering about C as well, because he doesn't have anybody to pick up his meds.
Oh, I didn't read all of that either. So B, C. Well, I would say, but most, I don't know. I would say B, C, and E.
Yeah, that's what I'm thinking. B, C, and E. Oh,
Oh, it's
all
just
right.
B and E.
B and E. Okay. All right. So we see this a lot, right? I mean, on the whole, there is limited psych services, I would say, predominantly. So what can you do if your med-surg patients are having psych problems such as depression or anxiety? Well, let's think about this. First of all, evaluation. Yeah, they have to have, and it depends what we're talking about here. If it's an acute psychosis or not. So let's have a look. Yeah, just what I said. So assessment. Obviously, if there's a psychosis going on or they want to harm themselves, that's a big deal. So it could be that we're going to have to Baker Act them potentially. So I do want you to have a look at that one, because these are the types of things that could come up, especially if you've got a case management type of question. Okay. Maybe restraints. It says here, right, social services, might need to get them involved, and seeing if you can get the patient transferred to psych, possibly. No. All right. So stop presenting there. Okay. So I have two big case studies, and I'm not sure if we're even going to get through them all, but we can try for sure. That's one, and then this is two. Let me see which one I want to do first. I think I want to do yeah, I think I want to do this one first. All right, we'll try this. Give me a second. So can you see this case study here? This one right here?
Yes, ma'am.
Yeah. Okay, I don't know if it's big enough, that's all, just making sure. So anyway, we've got this, looks like this RN, and, you know, just like we were talking about, the problem is if there's not enough staffing, often they'll use UAPs to staff the unit, okay? He doesn't feel, he's a little bit concerned about being that supervisor and making those decisions that he needs to make. And so it looks like he goes to his manager. Carlene explains that Sean will continue to be accountable for the patient's initial and intermittent assessments, planning, diagnosing, evaluating, patient teaching, and the UAPs are going to be for the direct care. So he's still concerned about that, and he's concerned about UAP training programs, and he's concerned about their knowledge. So here are some of the things that they're saying that could be helpful to create a plan to make sure the UAPs can be delegated, all right? So the process for framework for a plan to delegate according to the Nurse Practice Act rules and regulations. So the first thing, illustrate how a delegation process should be or could be used to evaluate the UAP's readiness. So the reason I referred you to that delegation tree in your book is that might be helpful to help how you delegate personnel, you know. So you may have to look at that, for instance, and that might be a good method. I'm not saying that you're going to have to commit that to memory, but it's something that you could look at. So that's one way. All right, let's name two tasks that may not be delegated to a UAP.
Passing meds.
Yeah, definitely.
Anything that you would teach?
Mm-hmm. Assessments, patient assessments as well, right? They're certainly not going to be doing that, are they? I mean, it's a task, but it's not the type of task you want to delegate, for sure. So like I just said, planning, evaluation, teaching, medication administration, calling the physician, right? You're not going to do that. No way. That's not going to happen. Let's see. Review your State Nurse Practice Act and discuss what guidance your state provides regarding delegation to the UAP. So what I just wanted to point out in this is the Nurse Practice Act. Remember, we talked a little bit about that last week, and I do suggest, you know, if you're in Florida versus Georgia, that you have the opportunity to just look at the Nurse Practice Act so that you can get an idea of what is appropriate in Georgia versus Florida or wherever else you may end up, okay? Certainly if you're going to be in a sort of supervisory role. Okay, let's look. And that's all I have on that one. So I'm probably going to have some time over. All right, here is the other case study. So she's a staff nurse. She just received report from the RN from the previous shift. She looks over her assignments. She sees that the nurse manager has scheduled an LPN to float over to Med-Surg from postpartum. Sarah is assigned to supervise the LPN and orient her to the unit. Sarah also has a UAP, to work with her. She's worked with her for about 8 months, so she knows her pretty well, right? She reviews the tasks. 3 patients are receiving IV antibiotics and they need labs monitoring. There's a new diabetic that's going to be discharged and needs patient education about diabetes management. There's 2 post-op patients that need dressing changes and assistance with ambulating. There's a stroke patient that's stable. The routine activities of patient assessments, updating care plans, taking vital signs, assisting each patient with hygiene, giving meds, passing trays, stocking carts, answering lights must also be accomplished. In addition, Sarah knows that she's going to have to spend time orientating the LPN to the unit. So, what should be included in Sarah's plan to orient the LPN to the unit? So what types of things are you going to do? She's not worked on this unit before. She's been working in postpartum.
Show her where everything is located on the floor as far as like supplies that she may need to care for the patient.
Yeah, absolutely. And, you know, patient policy, the policies and procedures as well. That's another biggie that she may need to know, right? She'll need to, you know, talk to her about infection control, for instance, and emergency procedures. That's a piece of it as well. And what's her experience? Okay, she's been working in postpartum, but she may have only done that for like 6 months to a year or something. And prior to that, she may have 10 years of Med-Surg experience, right? So talking to her, what's your experience? What have you done? Well, I've done this, that, and the other. Okay, great. She might have a ton of experience. So you're going to verify that knowledge, and you know, you might need to make sure she knows how to access resources, where the emergency equipment is. Okay. Introduce her to everybody. And one of the things it's saying right here, the promotion of socialization within the unit is paramount as part of orientation and mentoring. Don't you find that in any situation? Let's think about that. When you walk onto a new unit or walk onto that environment, and she's new, she's going to need to ask questions. She needs to feel that she's welcome and that she can ask questions, right? That's an important piece of it, because if they're all looking at like you know, who are you and we don't want you here, then she's not going to ask questions and she's more likely to make a mistake. So that's something we have to look at as well. Okay. Let's see. When reviewing the tasks to be completed, What may Sarah delegate to the LPN? So what can she do? All right, so what have we got? We've got 3 patients receiving IV antibiotics and need their labs monitoring. Can she do any of that? She can do that. Yeah. What about a newly diagnosed diabetic that needs continued patient education about diabetic management? Remember what we looked at earlier about maybe the RN should be the one doing more of that type of thing, that sort of deeper dive type of stuff, right? What about 2 post-op patients that need dressing changes and assistance with ambulating? She could do that, right? What about a stroke patient that's stable? Now they do need a nursing assessment and a care plan. Can she do that? No. Okay. All right, and the rest of it, what about giving meds? You can give meds. Yeah. Okay. So let's look at some of these. It says with the exception of IV meds, by the way. So I think, you know, and it's interesting to me because I think that depends on the organization. So I'm not 100% sure whether they can give IVs or not. I thought they could if they've taken their IV course, if they've taken that particular, you know, the IV
Certification.
Pardon?
IV certification test.
Yeah, I thought if they've taken the IV certification course, they could give IV meds. So
And when I lived in Georgia, LPNs couldn't do IVs.
they could not, or they could? They could not. Okay. So that could be the case then. So that's a perfect example, right? Where the Nurse Practice Act regarding states, they may not be able to do that. So, all right, let's look at some of the other things. Sarah is going to do the plan of care for the stroke patient, but she could delegate some of the vital signs and things like that and monitoring the patient for sure. She could do the dressing changes, but it's saying here Sarah should ask the LPN to assist her with the dressing changes, and then if she's okay at it, if she feels that she can do it, then she could let her carry on doing them. Okay. What about the UAP? Let's see what we've got here for the UAP. You can go back up. So we've got vital signs, we've got personal hygiene, we've got passing meal trays, stocking the supply cart, answering call lights. You think a lot of that could be delegated to the UAP?
Yes.
Yeah. Yeah, definitely. Okay. Let's see. What patient care activities must be done by Sarah and cannot be delegated? Let's go back up to the top. What types of things?
The assessment.
Yeah. Care plans, assessment, teaching, all of those types. And it looks like IVs as well. Okay. Those are the things that definitely have to be done by Sarah, the RN, for sure. Let's see if there's anything else. Here's another one as well, reviewing lab values. Okay, so, all right. So that's all I have for you, which is actually quite a lot, isn't it? Made sure I did my homework for you guys. But yeah, it actually was quite a lot. Now, I don't know if you want any of those case study things, but I really just wanted to go through them because I think ultimately now it's a case of you looking at that HESI prep work and sort of teasing out from that the areas that you may not be comfortable with, meaning it could be meningitis that you need to look at, or it could be acute kidney insufficiency or asthma, or some of these pieces that you may just need to review a little bit more, you know, and look at. Yeah, and so I am gonna, let's just see if I can stop recording at least. Where am I?